Hello and welcome. We are happy that you have decided to join us for this training on building of communication skills for boosting routine immunization demand generation. This is a self-placed training package that has been developed for you to understand the role that communication plays and also to support you in build skills for communication. The training package comprises of 3 modules and the introduction session. You may click on each module given here to know more about that module. Introduction. This section will give you the background to this training, why the training is required and what it will be focusing on. The section will also have the training objectives and a pre-training assessment for the participants. Complete this section and then move to the next one. This section will take approximately 20 minutes at a comfortable pace. What are we going to learn in this training program? After completing this training, you will be able to effectively mobilize parents or communities for routine immunization, RI, deliver key messages on RI and new vaccines introduced, improve vaccine confidence and reduce vaccine hesitancy among communities by answering their concerns effectively, track children and especially dropouts and left-outs and follow up on immunization, use a planning template to prepare a village-level communication plan, deliver updated information about COVID-19 and allay community fears about vaccination and COVID-19. This shows us the immunization coverage trends in India for 2018 to 2020. The last column shows you the difference between coverage in 2019 and 2020 for some of the main vaccines in India. Coverage for BCG given at birth and DPT-1 have both reduced by 7% in 2020. As we can see in this figure, there are just 10 countries in the world that account for 62% of the UN and under-vaccinated children. And of these, India has the largest drop in coverage in 2020 from 91% to 85% and becomes the country with the largest number of unvaccinated and under-vaccinated children in the world. Given the COVID situation, this figure looks at all the reasons why children missed all or some of the doses, and you will see that 32% of the parents went to the vaccination site but came away without the child receiving the vaccine. Another 16% were not aware of the vaccine session being conducted and 15% did not go because of fear of COVID. Fear of AEFI accounts for 4% of the left-outs and dropouts. From the earlier figure and this one, we can see the reasons why children are missing vaccination are because we have a gap in communicating the necessity and importance of childhood vaccination. Given the COVID-19 pandemic, globally, the vaccination rate for 3 doses of diphtheria, tetanus and pertussis DTP3 vaccine fell from around 86% in 2019 to 83% in 2020, meaning 22.7 million children missed out, and for measles first dose from 86 to 84%, meaning 22.3 million children missed out. Vaccination rates for measles second dose were at 71% from 70% in 2019. To control measles, 95% uptake of 2 vaccine doses is required. As part of our work for getting children to the immunization site, we will have to work and focus on 3 types of families. We will call these families the low-door families. They are left-outs, dropouts, and resistant. Take a minute and read what each one stands for. Now that you have read the definitions, let us understand that these families are the priority families with whom we will be working. This training is for increasing our skills to communicate and motivate these families to bring in their children for immunization. Before we start our training, let us do a quick self-assessment of our knowledge and attitude. You will see on your screen 12 statements that you must mark as yes if you agree with the statement, or no if you disagree with the statement, or don't know if you do not know. That is a very good self-assessment that you have done. I have a small work for you here. Pictures A to E show an Asha in blue sari discussing routine immunization in a village. Try and arrange these pictures in the correct order from awareness to actual immunization. Correct order will be information and awareness on routine immunization, first immunization, dropout, home visit of dropped out family and discussions with mother, husband and mother-in-law and mother bring child for next immunization. What if the Asha or the A&M is removed from these pictures? Tick mark all that apply. So, A&M, Asha, AWW are an important link with the community. You are the health department's bridge with the community. That is why this training program is called Bridge. Bridge is also used to refer to boosting routine immunization demand generation. A frontline worker means A&M, Asha, AWW is the bridge with the community for increasing the demand of routine immunization. Without you, situation may not remain the same, it may even become worse. As a bridge in the community, the frontline workers, FLW, help in increasing demand for routine immunization by creating awareness, discussing doubts and problems with parents, involving community influencers to mobilize parents, providing post-immunization support to parents. Communication is the most potent tool with the FLW. 3 approaches of communication are often used. These are one-to-one or interpersonal communication, conducting small group meetings and community meetings, advocating with local influencers for mobilizing community participation. Now that we have seen this game, we understood that the frontline worker is a link between the community and the services that need to be leveraged. A skilled frontline worker is that much more effective in ensuring that all the services get used by those for whom they are meant and every child gets covered for immunization.